Well, welcome. We are starting on the section of our selective lecture series on the larynx. I'm Julina Ongkasuwan. I am an assistant professor in the Department of Otolaryngology, Head and Neck Surgery. Specifically, I am a laryngologist, so I only deal with the larynx, though I see adults and children. So this first lecture is going to be focused on the anatomy of the larynx. So, to begin with, where is the larynx relative to the rest of the structures of the upper airway? So if you look at this diagram, this is a sagittal view of the upper airway. You can see, starting at the top, you have your nasal cavity here. It is separated then from the nasopharynx by the soft palate. The soft palate then, in a horizontal dimension, separates the nasopharynx from the oropharynx. The oropharynx also encapsulates the tonsils and base of tongue. And this oropharynx ends at about the level of the hyoid bone. And then inferior to the hyoid bone, including the larynx, as well as the piriform sinuses, is going to be known as the region of the hypopharynx. And the larynx sits within the hypopharynx. So to give you, again, another way of looking at this is in a three-dimensional model. You can see the mandible and the tongue. The base of tongue comes here, and then you can see the larynx sits within this three-dimensional structure known as the hypopharynx. These two gutters on either side of the larynx are known as the piriform sinus. Okay. The extrinsic musculature of the larynx. It helps put the larynx in context. So we're lucky in the head and neck that most of our muscles are going to be named after their origins and insertions, with a couple exceptions. So to start with, you have your mylohyoid muscle, which comprises the floor of mouth, and the anterior and posterior bellies of the digastric muscles. These muscles are superior to the hyoid bone. And then this is your hyoid bone. Okay. This large muscle in the neck is the sternocleidomastoid. Again, starting at the sternum and having an attachment at the clavicle, going all the way up to the mastoid, hence sternocleidomastoid. The rest of the muscles in the neck we collectively refer to as the strap muscles, though they do have individual names. So we'll start from lateral and move medial. So the lateral most strap muscle is the omohyoid. It has two bellies, again, kind of like the digastric muscle. The next is the sternohyoid muscle. This is, again, attaches at the sternum and goes up to the hyoid bone. The next medial muscle, if you look on the side where we virtually pulled the muscles aside, you have the sternothyroid muscle, as well. The muscle going from the thyroid to the hyoid bone is known as the thyrohyoid muscle. And finally, the muscle going from the cricoid to the thyroid cartilage is known as the cricothyroid muscle. So to give you, again, context within this three-dimensional model of the larynx, the cartilaginous and bony structures of the larynx going from superior to inferior of the airway. Again, here's your mandible superiorly. You have your hyoid bone. Then you have your thyroid cartilage. It's this big shield-like cartilage. And the larynx sits within this thyroid cartilage. The membrane between these is the thyrohyoid membrane. The next cartilage moving inferiorly is the cricoid cartilage. It is different from all the other airway cartilages because it is a complete ring. You see it has a posterior component here. And then the next airway cartilages moving inferiorly are going to be your tracheal rings. Overlying the inferior portion of the cricoid and the upper tracheal rings is going to be the thyroid gland. Okay. So again, you can see here's a representation of one of these strap muscles. This is likely going to be the thyroid hyoid muscle. as well as here on this model you can see a muscle going between the cricoid and the thyroid cartilage, and this is going to represent the cricothyroid muscle. So the cricothyroid muscle is actually one of the intrinsic muscles of the larynx. So these are the muscles that are largely going to control the movement of the vocal folds. Okay. The vocal folds are located within the larynx. So we can look at our model, take our model apart, and in sagittal view here, you can see this structure is known as the epiglottis. This is the arytenoid. The fold of tissue going between the arytenoid and the epiglottis is known as the aryepiglottic fold. The true vocal folds sit here, going from anteriorly attaching to the thyroid cartilage, posteriorly attaching to the arytenoids. Above them there's a fold of tissue known as the false vocal folds, and between them a space which we refer to as the ventricle. The true vocal folds are known as the glottis. The area above the true vocal folds, going from above the true vocal folds including the epiglottis, is known as the supraglottis. And the area below the true vocal folds, just below the vocal folds, ending at just below the cricoid, is known as the subglottis. Okay. So when we breathe, the vocal folds open to allow air in, and when we talk, when we swallow, when we cough, the vocal folds close. So the opening of the larynx is also known as abduction. So the only muscle which opens the larynx is the posterior cricoarytenoid muscle. So again, it's named kind of after its origins and insertions. So this is a diagram of the larynx looking superior to inferior, looking at the cartilaginous structures. So to orient you, this is the thyroid cartilage. This is anterior. Here's the cricoid cartilage. You can see the complete ring of the cricoid. Sitting on the cricoid, you can see your arytenoid cartilages here. Okay. These white lines in a V represent the true vocal folds, again attaching anteriorly on the thyroid cartilage. So the posterior cricoarytenoid are located in the posterior portion of the larynx, and they attach from the cricoid to the arytenoid cartilage. And when they contract, they rotate the arytenoids on the cricoid, and in this circumstance, they cause then the larynx to open. All the rest of the muscles of the intrinsic muscles of the larynx are geared towards closing the vocal folds or tensing them. And closing the vocal folds is known as adduction. So the lateral cricoarytenoid, again describing its location, it's located laterally in the larynx, attaching from the cricoid to the muscular portion of the arytenoid. Again, when it contracts, it causes the arytenoid to rotate on the cricoid, causing vocal fold closure. And then the interarytenoid muscle, which is located between the arytenoids, also causes the vocal folds to come together. The thyroarytenoid muscle, which is the muscle that comprises the bulk of the true vocal fold, goes from the thyroid cartilage anteriorly to the vocal process of the arytenoid, and this again is what comprises most of the true vocal fold. The most medial portion is often referred to as the vocalis, but this is also involved in adduction as well as tensing the vocal folds. The cricothyroid muscle that we alluded to earlier attaches from the cricoid cartilage to the thyroid cartilage. So you can see this is a sagittal view again. So when the cricothyroid muscle contracts, the cricoid cartilage tilts posteriorly, and because the arytenoids are attached to the cricoid, that then causes the thyroarytenoid or the vocal fold itself to lengthen. So you can think of it as a rubber band that you put tension on. If you then vibrate it, the more tension you put on it, the sound pitch is going to go up. So the cricothyroid is the primary muscle involved in pitch control of the larynx. The vocalis muscle and thyroarytenoid muscle are also involved in tensing the larynx in addition to adduction of the larynx. So the innervation of the larynx, the majority of the motor innervation to the larynx is done by the recurrent laryngeal nerve here, which is a branch of your vagus, which is cranial nerve 10. It recurs. The vagus descends from the brainstem down the carotid sheath into the chest. On the left side, the recurrent is going to wrap around the arch of the aorta. On the right side, it's going to wrap around the subclavian artery, and then it's going to come back up in the tracheoesophageal groove before entering the larynx. So the recurrent laryngeal nerve innervates all of the intrinsic muscles of the larynx except for the cricothyroid muscle. And the cricothyroid muscle, which again is in charge of pitch control, is actually innervated by the superior laryngeal nerve, the external branch of the superior laryngeal nerve, okay, which is also a branch of cranial nerve 10. Okay. The superior laryngeal nerve also has an internal branch, and this internal branch does sensation to the supraglottis. Sensation to the glottis itself is provided by the recurrent laryngeal nerve. All right, so the vocal fold itself is actually comprised of a multi-layered structure. So if you look at this is a coronal view of a vocal fold. So this is the expanded view. You can see here's the true vocal fold, the ventricle we talked about, and the false vocal fold on top. So if you look at this under a microscope, what you're going to see from superficial to deep is you have a layer of epithelium, right? And then beneath that, there's an area called the lamina propria, which is a trilaminar structure. It's got 3 layers, a superficial, intermediate, and deep layer. And then beneath that is going to be your muscle, which is most medially going to be referred to as the vocalis muscle, or the thyroarytenoid muscle. The intermediate and deep portions of the vocal fold of the lamina propria are referred to as the vocal ligament. So how do we make voice? So the vocal folds are placed in approximation by those intrinsic adductory muscles. So those place the vocal folds right in approximation. Then the air passing between the vocal folds then causes them to vibrate. So this is called the glottic cycle. So you can see a picture of this here. You have your vocal folds in approximation. You build up subglottic pressure between the vocal folds, which then blows them apart. Then you end up, because you have air passing through a relatively narrowed area, you have a Bernoulli effect. You get some turbulent air behind here, which then results in negative pressure, which sucks the lower lip of the vocal folds together, followed by the medial lip and the upper lip. And then you're back in this closed configuration. And then the air passing through it again blows the vocal folds open. The lower lips get sucked together again, medial and upper. So this is called the glottic cycle. Okay. So the act of pushing the vocal folds together into adduction is an active act by the muscles. However, the vibration of the vocal folds is a passive phenomenon, with the air passing between the vocal folds causing them to vibrate. Just like if you've ever taken a blade of grass and blown on it between your thumbs to make a whistle, that's the same idea, that the air passing between the vocal folds is making them vibrate, which generates sound. All right. Now the vocal folds vibrate really quickly. In a female, they on average vibrate about 210 hertz. In a male, on average, around 120 hertz, which is way too fast for the naked eye to be able to resolve. So we use instruments called stroboscopy, or strobes, laryngeal strobes, in order to be able to slow down that vibratory motion to evaluate it. So this is a laryngeal stroboscopy. So you can see the vocal folds opening when she takes a breath, and as she's phonating, you can see them vibrating against one another. All right, so how do you examine the larynx? It's a hard place to look at because it's inside your throat, so you need some sort of instrumentation to look at it. So you can either do indirect laryngoscopy or direct laryngoscopy. Indirect laryngoscopy means we use either fibers or lenses or something to bend the light. So the old-fashioned way is with a mirror and a light source. And this was described first back in the 1800s, where you put the mirror into the mouth and you use it to reflect light down onto the larynx. What you'll see most often in an inpatient or outpatient setting is flexible fiber optic nasolaryngoscopy, where a scope is passed through the nose, through the nasopharynx, and then allows visualization of the larynx. Another way of doing this is with transoral rigid laryngoscopy, which is what you just saw in the previous video. This is a Hopkins rod telescope with an angled lens, in this case usually a 70-degree angled lens, which then allows you to visualize the larynx this way. Now, direct laryngoscopy is different because you then use an instrument to look directly at the larynx, so you don't have to bend the light in any way. This is typically done in the operating room because it's pretty uncomfortable for the patients, and we use, again, rigid scopes to essentially push the tongue out of the way and lift the mandible up in order to look directly at the larynx. And this is also the way in which we do microlaryngeal surgery. So, we've been talking a lot about the larynx, but what is the difference between voice and speech? So, if you think of the lungs as your power source, the larynx, your voice box, is really just a vibrator. All it does is it generates noise, a sound. It's your resonator, which is your mouth, your soft palate, your tongue, which then shapes that sound into speech. So it's very important to think of them as separate things. So voice represents purely the sound signal coming from the larynx. Speech represents how we shape that sound into words. When you think of a patient who has problems with speech, we call that dysarthria, versus a patient who has hoarseness. If a patient presents with one or the other of these diagnoses, of these symptoms, it's going to lead you down a different diagnostic path. So dysarthria means difficulty with articulation of words, whereas hoarseness means the sound signal is going to be noisy. You're going to hear breathiness or roughness or raspiness in the voice. Okay. With dysarthria, you may think that there's something wrong with the palate or tongue. You may also think classically of a patient with a stroke or other neurodegenerative disorders. Okay. Whereas hoarseness, you may think of a lesion on the vocal fold, causing the vocal folds not to vibrate as well, causing noise in the sound signal. Or you may think of vocal fold paralysis. Okay, so what are the questions you should be asking if a patient presents with hoarseness? Sort of classic things are, how long has it been going on? Do they have any associated pain, whether it be ear pain or throat pain? Are they a smoker? Has this ever happened before? Was it a sudden and gradual onset? What were they doing? Were they shouting at a football game or something and suddenly lost their voice? Do they have to do a lot of talking in their job? What is their vocal load? Are they a singer? Are they rehearsing a lot? Are they practicing for a new show with a new voice part? Do they have associated with cough or difficulty breathing or difficulty swallowing? So we'll start with an example case. So case 1 is a 45-year-old woman who has a raspy, strained voice, which has been ongoing for a week, and she's been feeling sick. She has malaise. She's not having any pain, and she is a non-smoker. All right. And when you look at her larynx, this is a flexible nasal laryngoscopy, you see a lot of inflammation in the larynx as well as some ulceration and a lot of thick mucus. So the top of the differential is going to be a laryngitis. The most common cause is a viral infection, though occasionally you can get really bad ulcerative laryngitis, which is thought to be bacterial in origin. And it may also be exacerbated by laryngopharyngeal reflux. So treatments might include voice rest, voice therapy, hydration, reflux medication, but it's a largely non-surgical management for this particular disease process. And then I would typically rescope them in about 6 weeks to ensure resolution of this. Case 2 is a 62-year-old man with a rough, raspy voice lasting approximately a month with throat pain and ear pain. He also smokes a pack a day. When you do your flexible nasal laryngoscopy, you see this white lesion, which we call leukoplakia, leuko meaning white, plakia meaning plaque. So a white plaque on the right vocal fold here. Okay. So the top of my differential in this particular patient who's a smoker with ongoing throat pain and ear pain is going to be a laryngeal carcinoma. Okay. The most common type of laryngeal cancer is going to be squamous cell carcinoma. And these are typically associated with tobacco and alcohol. So what would your next step be? How do you confirm this diagnosis? So in biopsy, you have to biopsy the lesion. Should it come back as a carcinoma, in order to stage it, typically you would need a CAT scan of the neck to assess for any associated metastatic lymph nodes, as well as a chest x-ray to assess for lung metastasis. Treatment for laryngeal cancer does depend on the stage. It can include surgical excision with or radiation for early stage lesions. Chemotherapy plays a role in more advanced tumors. Okay. So our third case will be a 67-year-old man who has a history of having undergone an aortic arch repair. With a weak, breathy voice after extubation and a weak cough. In addition, he chokes on thin liquids. When we put the scope down, when he takes a breath, this is what you see. The right vocal fold, you can see, has good abduction. The left vocal fold is rather flaccid and not moving to the breath. And when he goes to phonate, the right vocal fold is trying to move in. The left vocal fold remains flaccid and immobile, and there's a large glottic gap resulting in a very breathy voice when he tries to talk. So what's the diagnosis? He has a left vocal fold paralysis. The cause of this, given the patient's history, is likely injury to the recurrent nerve where it crossed under the aortic arch after his aneurysm repair. It can also be caused by a cerebrovascular accident. Other things that can cause vocal fold paralysis includes various neoplasms along the course of the recurrent nerve. These can include thyroid cancer, lung cancer, esophageal cancer, or mediastinal lymphadenopathy, among many other things. We also see infectious or idiopathic etiologies causing vocal fold paralysis. So what can you do? You can do medialization procedures, whether they include injections or thyroplasties. Medialization procedures, including an injection medialization or thyroplasty to push the immobile vocal fold over to the midline, such that the mobile vocal fold can then make good contact, and you can usually restore normal conversational voice with these types of procedures. You can also do laryngeal reinnervation procedures to try to restore some of the tone to the larynx and give people back their voice. There are other myriad different types of lesions that we can see in the larynx that I treat as a laryngologist. These include vocal fold polyps and nodules, which you can see in in singers, but also in anybody who uses their voice a lot, such as teachers, lawyers, doctors. Also see vocal fold cysts, granulomas, papillomas, and hematomas, or just a smattering of the different types of laryngeal pathology which we see. So this slide represents different types of laryngologic surgeries that we can do. This one represents microlaryngeal surgery, so we do it through a direct laryngoscopy approach like we showed before, and we can work under the microscope to excise various lesions of the vocal fold. This is a diagram representing a type 1 thyroplasty or medialization procedure where we can actually implant through an open neck approach an implant that pushes over our paralyzed vocal fold to restore voice. Is actually done awake, where we hand carve an implant to size and suit the individual patient and then restore their voice immediately there on the table. So this concludes the lecture on our introduction to laryngeal anatomy. If you have any additional questions, please feel free to email me at julinao@bcm.edu. Thanks.